Welcome to this episode of Sleep Health with Dr. Alison Bentley. In this episode, we're going to be talking about medications used for insomnia specifically. Now, the talk is really designed for doctors, and so I apologize if people are listening to this and are a bit befuzzled by the medical jargon and the medical language. But it's important to understand the principles. There's still a lot of information here which would be useful to anybody. So first, I think we need to talk about insomnia and really why we would even want to treat this. So the problem with insomnia is not just that you sleep less hours at night. So people will tend to go, if I don't sleep 7 to 8 hours, that must be insomnia. That's not really the definition. The definition is that you only sleep 5 hours a night, but you need 7. So there's a mismatch between the amount of hours that you sleep and the amount of hours that you need. And what that means, and part of the definition of insomnia, is that there has to be a daytime dysfunction. And that dysfunction often is poor concentration, poor memory, very rarely sleepiness, but often a lot of fatigue during the day. So there are consequences to not sleeping well, and that is insomnia. If you only sleep 5 hours, but you function extremely well during the day, never need more than 5 hours, couldn't get more than 5 hours even if you tried, then that's not insomnia. That's just a naturally short sleeper, and it is a gift that you are able to do in 5 hours what it takes everyone else 7 to 8 hours to do. So insomnia, very specifically, you have to have a daytime dysfunction. And it is in fact that daytime dysfunction that produces the consequences. So there are immediate consequences for those people who work. The drop in productivity is noticeable. You're aware that you're not functioning well during the day. But there are also long-term consequences to insomnia, and these include increased risk of cardiovascular disease, increased risk of depression, which is really quite high, increased risk of anxiety, things like increased risk of dementia, and then just an economic cost because of the increased sick days that people with insomnia are likely to have, and a cost to the health industry because often they're attending doctors' rooms and looking for help a lot more than other people are looking for. So there is a good reason to treat insomnia, and this episode is really looking at how we do that. Now, when we look at how we would want to treat medically, so we're looking at pharmacologically using medication to treat insomnia, it's really important to look at the background to sleep and what it is that we're targeting. So there are two main groups of neurotransmitters in the brain that we're targeting. The one group is like the accelerator in a car, so it keeps us awake. And there's two main compounds there. One is orexin and the other one is histamine. And then there's the brake component to sleep, and that is GABA and melatonin. So if we look at orexin first, orexin is a group of neurons in the hypothalamus which produce orexin, and that compound specifically is important for maintained wakefulness. So it's what keeps us awake for 16 hours during the day so that we can then get 8 hours sleep at night. It's also very important for the control of REM sleep. And in fact, the key problem with orexin is if you lose those neurons at a young age, then you develop narcolepsy. But we're not talking about narcolepsy today. But narcolepsy then presents with inability to stay awake, so sleepiness during the day, and abnormalities in REM sleep. So that's orexin. And we have no real compounds that work on orexin at the moment, but the orexin antagonists, i.e. those compounds that would switch off orexin, i.e. take your foot off the accelerator, are coming. So they'll be coming in 2 or 3 months. Then when we look at histamine, so we know that you can use antihistamines, that people who take antihistamines for allergic responses, for example, often feel very sleepy. So antihistamines are used for sleepiness in a lot of the over-the-counter products, such as antihistamines, full-blown antihistamines, or side effects of other medications such as antidepressants. So that's the accelerator. So what we want to do is pull the foot off the accelerator when people are trying to sleep, and then we want to put on the brake. So the two compounds there are melatonin and GABA. So melatonin, as we know, is a compound that is used for the timing of sleep specifically. So that would be increased melatonin at night. So melatonin produced at night causes the body temperature to drop, and that dropping of the body temperature is what makes us feel sleepy at night. So there's an increased sleepiness when melatonin increases. And then the other one is GABA, and GABA is the compound that all of the benzodiazepines work on. So all of the registered sleeping tablets will work on increasing the amount of GABA and therefore putting the foot on the brake. So this concept is important to take the foot off the accelerator and put the foot on the brake if you want to fall asleep. Now, tied into that is it's important to understand that insomnia is just not one disorder. There are multiple reasons why people might have insomnia. And it's really important to make sure that before we put patients on medication, that we make sure that we are not medicating the wrong thing. So there are significant causes of insomnia that we need to check on. So medical causes of insomnia. So lots of medical disorders can cause insomnia, ranging from pain, from anything. So arthritis, any kind of lupus pain. So generalized muscle pain can cause insomnia. But something like asthma, where there's an increase in resistance to airflow in the middle of the night. So waking up, battling to breathe at 2 or 3 o'clock in the morning. Angina that could occur in the middle of the night. All of these are likely to cause insomnia. And then we also know of about 180 medications that are likely to cause insomnia. The big ones that we know about are the statins for cholesterol. Any kind of cortisone can produce insomnia, but things like the old antiretrovirals cause insomnia. So many medications cause insomnia. And in fact, the increase in insomnia in the elderly patients is because they have more of these medical disorders, are taking more medications, and the likelihood of some of those interfering with sleep actually becomes higher. So that's the medical causes. Then there are full-blown sleep disorders, which we have to exclude in patients with insomnia because simply giving medications for these particular disorders is not going to work. So things like restless leg syndrome, obstructive sleep apnea, and while it might seem odd for obstructive sleep apnea to cause insomnia, the data would tell us that 30% of men who have sleep apnea actually present with insomnia symptoms, not with the traditional good sleep and feeling sleepy during the day. So it's important to ask patients about, do you have an urge to move your legs at night? Do you snore? Has anybody seen you stop breathing? Because these are not necessarily symptoms that patients are going to tell you. You need to ask these questions. They're very simple questions. If there's a yes to any of those, then there can be some further information and going into those kind of topics. A big sleep disorder that we need to look at is one of the circadian disorders, and it's called delayed sleep phase syndrome. Now, this is like a social jet lag, where the jet lag happens. The sleep is delayed, so there's an inability to fall asleep. And key to that is patients saying, I'm just not sleepy. I'm not sleepy until about 2 o'clock in the morning. But once I fall asleep at 2 o'clock in the morning, I can sleep till 9, 10 in the morning with no problem. So there's a delay in the sleep. It's just delayed in time. It's really important to find this disorder because it's not treated with your standard hypnotics. It's treated with melatonin and a very specific program to move the sleep back. Again, using medication, so hypnotics in patients with restless legs or sleep apnea or delayed sleep phase is not going to work. And so you need to find these disorders. The same thing counts for the naturally short sleeper. Really important to find patients who only need 5 hours of sleep, because trying to create 8 hours in a person who genetically is programmed to get 5 is doomed to fail. And they often end up on lots of medication for no reason whatsoever. So let's exclude those patients where they have a sleep disorder, so we don't need to treat those. Then if we look then at insomnia, and if we particularly look at the DSM-5 classification for insomnia, there are 3 types of insomnia. The one we've already dealt with, and that's the secondary insomnia. So those patients who have insomnia which is caused by something else. The other 2 types of insomnia, acute insomnia and insomnia disorder, are important to know about. The acute insomnia is many people have acute insomnia, and it's caused by some kind of stress, usually a psychological stress. So any life event that's significant, which may range from moving house to being divorced to having exams to just having a stockbrokers meeting, anything that causes stress, which then interferes with falling asleep. Now, it can be a physical stress as well. So, for example, post-operatively, if you are post-op, you have pain, but it's an acute experience, so you will have pain for a little short period of time. You may have insomnia because of that pain. But what we know about acute insomnia is that 75% of people who have acute insomnia, the insomnia is going to resolve. So as the stress goes away, or the emotional part of the stress goes away, the sleep comes back. And so most people are just going to have a short period of insomnia, and then their normal sleep will come back. You can't say, well, why would we bother to treat that? Well, if you're going through a psychological stress and you're not sleeping, it makes it much harder to manage that stress. So the advice would always be to treat that insomnia, usually with a hypnotic, for 7 days to give the patient some good sleep so they can deal with the stress better. because 25% of people who have acute insomnia are going to move on to chronic insomnia. And we'd like to prevent those 25% moving into chronic insomnia, which then becomes harder to treat. So the management of acute insomnia would be medication, and it would be a benzodiazepine type medication, which is the best medication for that situation. When we move into insomnia disorder, now insomnia disorder used to be called chronic insomnia, but that implied that acute insomnia just moved into chronic insomnia just because it had been there for long enough. So if you had insomnia for 3 months, you just had a name change that went from acute insomnia into chronic insomnia. But that's not actually how it works. So insomnia disorder is a better name because what happens with insomnia disorder, it's a different type of insomnia. So when you have insomnia for more than 3 months, it's not the same thing. So generally the stress is not there. Most patients who have chronic insomnia, when they approach a healthcare professional, will say, I don't understand why I can't sleep. I don't have this stress. I don't have that stress. There's no pain. There's no this. There's no that. I have no idea why I can't sleep. So there's no clear cause. Where there is for the acute insomnia, there's a clear cause for insomnia. So for the chronic insomnia or the insomnia disorder, there's no cause. And what's happened here is it's moved from a precipitating event into a self-sustaining type of insomnia. Now, at this point, the reason why the insomnia there is all about the cognitive changes that have occurred in that patient, and that's really about the thinking, how you think about your sleep, and the behavioral changes, how you've changed the behaviors around your sleep. And we know that every insomniac who moves into this zone starts becoming very anxious about sleep. And if you say to patients who have insomnia disorder, before you had insomnia, how often did you think about sleep? And they would go, hardly ever. Like, I'd just have my day, go to bed at night, and it would be quite quick. Now I think about sleep all the time. I'm worried about my sleep. How am I going to sleep tonight? I'm aware that I haven't slept well because of the daytime fatigue. So there's lots of changes in their thinking about sleep, and these are called perpetuating factors. They perpetuate the insomnia, they keep it going, and patients will describe how after dinner they start getting anxious about their sleep, which never was there before. So that's an important component. This anxiety is not generalized anxiety disorder. It's a very specific, valid anxiety about sleep. They're anxious about their sleep. It's valid because they know they have a sleep problem. They know they're likely to have a sleep problem, so the anxiety is valid. So it doesn't necessarily need to be treated as a generalized anxiety problem. The behaviors that patients with insomnia usually do is that they generally go to bed earlier on their understanding that if they spend 7 hours in bed and they only get 5 hours of sleep, by extending that to 9 hours in bed, they're likely to get more sleep. That is not true, and so they don't get more sleep, but that is what they do. So they generally go to bed earlier, wake up later in the morning, extend that time in bed. Then they will also spend lots of time, hours and hours, lying in bed trying to fall asleep when they're actually awake. And what this induces is anxiety, more anxiety, but a thinking process which is really very destructive to sleep. So patients will talk about their mind is racing, they can't switch their brain off, they just seem to be thinking excessively. Also, what happens is it's not normal thoughts. I always explain to patients it's like your head goes into crazy land and you're thinking crazy stuff. So they will catastrophize, they will ruminate, and the thinking is what keeps them awake then. And then the other thing they do is not look at what's happening. Don't look at the clock because it creates more pressure if you watch the hours go by and you still feel as though you haven't slept. So this is what insomnia disorder looks like. They go to bed early at often 8:30 or 9 o'clock at night, plan to wake up at 6:30 the next morning, spend a huge amount of time within that period lying in bed trying to fall asleep, getting incredibly anxious about their sleep and failing to sleep properly. And that's the disorder that all of the hypnotics have been registered for to treat that particular disorder. So that's what we're really aiming at today. There's no question that the hypnotics can be used for other disorders. So if you have pain, it's very useful to use a hypnotic to help people fall asleep if the pain cannot be managed properly. So the pain and sleep interaction is quite difficult to manage, to get enough management of the pain without using meds that are going to interfere with sleep and then helping patients to sleep. I think part of the problem with hypnotics and using them is the urban legends that swirl around sleeping tablets about the fact that you're going to get addicted to them, you're going to get dependent on them, they have massive side effects, etc., etc. Well, I hope through the course, the rest of this podcast, I'll be able to show you that it's very unlikely that patients are going to get addicted, because that's a very special word and has a very special definition. It's very unlikely that patients are going to get addicted to sleeping tablets. Neither are they going to get physically dependent on sleeping tablets, and it's possible to get 3/4 of patients who are on sleeping tablets off them if you use the right kind of program. So that's what we're going to be talking about for the rest of this topic. Now, I'm not dealing a lot with melatonin and how we use melatonin specifically, because there's going to be a full podcast on melatonin because there's a lot of information there. But understand that, again, as far as melatonin is concerned, its registration in South Africa is for patients over the age of 55, because we know that that's a time when the melatonin levels are low. And if your sleep did depend on melatonin during your lifetime, as it goes away, your sleep is likely to crumble. So melatonin is useful in the older patient and is certainly useful, although not registered in South Africa for these uses, useful for children who have low melatonin, and that's particularly children with autism spectrum disorder or children with attention deficit disorder, or anybody who has some kind of brain damage which may have impacted the melatonin pathways. So what's really important about melatonin is not to just throw it at every patient who has insomnia, because I'm sure it'll work. It doesn't necessarily work, but it does work in specific circumstances where you can make sure that this is likely to be a melatonin deficiency and where melatonin is likely to work. So let's look at the hypnotics, or the medications that you would use for sleep. There are a lot of medications that are available over the counter for sleep. And as doctors, it's important for us to manage this process, because if we do not treat patients properly for their sleep, they will go for over-the-counter products, some of which are harmless and some of which are extremely harmful. So let's look at the harmless ones. So the harmless ones are things like valerian and lavender and a whole lot of herbal remedies, in which there are studies showing that they do increase the sleepiness. So they reduce anxiety, they increase the sleepiness and can help people fall asleep. Most patients who will to approach a medical practitioner for help with sleep have already tried all of these. And so they will go to the pharmacist and generally say to the pharmacist, please give me something to help me sleep. They're very focused on a product to help them to go to sleep, and the pharmacist will show them the ranges of herbal remedies. Often they all come together, so you'll find products that have valerian and lavender and this and the next thing and 5 different things all together. And there's no harm in trying those. There is some data to show that they do help patients fall asleep, but not everybody, so they're not going to help everybody. Then the more problematic, then also OTC, you can get antihistamines, OTC. So, the sleeping tablets that they would talk about from the pharmacist would be antihistamines. Now, the antihistamine studies that have been done, and there have been a number, there's a meta-analysis also looking at all of the studies together. What is the compounded effect? What it shows, I think the last data I looked at, there were 7 studies on antihistamines. The last data was they do improve subjective sleep. But if you look at what they're improving, they're not improving anything consistently. So each study would show a different effect, if that makes sense. So some would reduce sleep onset latency, making it faster to fall asleep. Others would stop waking up during the night, but they're not producing a consistent effect. So the data really isn't there to show that they are useful products. Also with antihistamines, the problem is they tend to be long-lasting, and so patients wake up in the morning with sedation in the morning, often with a very dry mouth as well. So patients will try these, and sometimes we use them as well because we don't want to use anything else. The more problematic over-the-counter products are alcohol and cannabis. So alcohol works extremely well for sleep. I mean, we all know that if we have an extra glass of wine, that it's much easier for us to fall asleep. But the problem with using alcohol specifically for sleep, and a trial even in the 1960s showed that if you restricted benzodiazepines from patients with insomnia, that alcohol consumption went up. If you use alcohol specifically to help you sleep, the tolerance is extremely fast. So within a week, you're going to be needing 2 glasses of wine. Within 6 days, there's good evidence that your sleep is now worse than it was before you started. So you're spending more time awake, you'll have less deep sleep, you have less REM sleep, more awakenings during the night, and so your sleep is worse. And so what tends to happen is that you take more alcohol to cover that problem. And so the alcohol consumption goes up, and it goes up quite rapidly. And within 6 months, you can have somebody who goes from a glass of wine to help them falling asleep to half a bottle of whiskey. Not because they're enjoying the whiskey, but they literally just drink it down in one shot because that's what they need to help them sleep. Now, no matter what we think about the benzodiazepines and the consequences of long-term use of that, the consequences of half a bottle of whiskey every night far outweigh the consequences of benzodiazepines. So we're looking at cardiac effects, we're looking at liver damage, we're looking at so much damage that occurs from alcohol. So be really careful about restricting medication for patients because they go to alcohol. Far fewer patients are going to go to cannabis. And when we're talking about cannabis or dacha, we need to differentiate between smoked or eaten cannabis, so the full plant, or CBD oil, or the CBD products that are available. Full cannabis works extremely well for sleep. The tolerance problem is exactly the same for alcohol. You need to use more and more and more. Chronic cannabis users, if they try to come off cannabis, there's a very severe insomnia that happens with multiple nightmares every night. And the withdrawal period where you can say you're off cannabis and sleeping normally can be up to 45 days of very, very poor sleep. And unfortunately, in those situations, we're often stuck because we don't have anything else to offer them to sleep because we're concerned about the addiction to cannabis and the addiction to other products. So they're particularly problematic. So that is not advised. The CBD oil and those kind of products, the CBD oil, there's no good evidence that it works for primary insomnia or for any other sleep disorder at the moment. There is preliminary evidence that some of the cannabinoids may be useful for sleep disorders, but the current products that are available over the counter, so CBD, is not really useful for sleep. However, it is useful for pain and anxiety. So if you have pain and anxiety and that is relieved by CBD, then you are likely to sleep better. But the impact on sleep is a secondary effect, not the primary effect. The THC, the amount of THC in the product is likely to assist sleep, but that's more problematic. So that's the data that we have on CBD and on cannabis. So we need to be careful as doctors that if we restrict treatment for insomnia to patients because we are anxious about the products, then they're likely to choose possibly something that's worse and has worse long-term consequences. So let's look at the benzodiazepines because they are the products that are registered for sleep. There's multiple of them. And they have different lengths of actions. They have different timings. So some of them work extremely quickly to get you to sleep, but they don't last for long. Others, will take longer to get you to sleep and are designed for sleep maintenance to improve sleep during the night. Now, every patient who goes on a benzodiazepine is going to ask, will it give me normal sleep? And the answer is no, it won't give normal sleep because the data we have is if you take normal sleepers and you give them a benzodiazepine, you're going to reduce the amount of deep sleep. So that shortens. You're going to reduce the amount of REM sleep. So the amount of the deep restorative sleep is going to be reduced relative to normal. But when you're talking to a patient with insomnia who's only getting 4 hours of sleep, if you give them a benzodiazepine, you're going to significantly improve that sleep to maybe 70% of normal. That last little bit is not going to be there. So it's important for them to understand that it's not completely normal sleep, but it is far, far better than what they're getting currently. Now, everybody's concerned about the addiction to benzodiazepines. I can tell you right now the chances of patients getting addicted to benzodiazepines is extremely low. And in fact, there's very little data showing that if you use benzodiazepines for sleep, that you're going to get addicted to them. That's very little evidence whatsoever. There is, however, quite a bit of evidence to show that if you use benzodiazepines, different products for anxiolytics, that you can get addicted to that because there's a feeling associated with that. So the addiction literature for the benzodiazepines is there if you use them as anxiolytics, but if you use them as hypnotics for sleep, there is not much evidence that patients get addicted. But there are 3 types of users of benzodiazepines. The first people who use benzodiazepines are addicts. So they're using other products, and they use the benzodiazepines either to reduce anxiety or to help them sleep at night because they're using other products as well. So everybody has patients who are using 15 benzodiazepines a day for whatever reason they're using it. But it's very rare that they started only using it for sleep. And it's very rare that that's the only product that they're using. They're usually using other products as well. Now, this is a specific group of people that we need to be concerned about. And of course, we need to try and get them off the benzodiazepines, but it's not really the market that we are used to managing with as far as sleep disorders are concerned and hypnotics. The second group of patients are those that are taking half a sleeping tablet at night, and they've taken it every night, and they've taken it every night for 5 years. The dose is extremely stable. They are sleeping very well on the product. They're waking up without any side effects or manageable side effects. They're functioning very well during the day. These are not patients who are addicted just because they've taken it for a long period of time. And these are patients who get shamed for taking these sleeping tablets for a long period of time. I think what's important is that we need to, as medical practitioners, is not shame patients if we're not offering them other alternatives. So if you're shaming patients and you're saying, I'm not writing you up for any more benzodiazepines because you're addicted to them, well, you'd better be offering them a program to get off them and something else that they're able to take instead of benzodiazepines. But they're not addicted. And we'll go into addiction, rebound, recurrence in a short period. But they're generally not addicted. Then there are patients that we all have that they have insomnia, they ask for something to help them sleep, and you give them a sleeping tablet, and a couple of things happen which indicate that there's a problem. So either they come back after 7 days and they go, it doesn't work, or they go, well, I took one tablet, that didn't work, and now I'm taking 2 or even 3 tablets a night, so I've run out of tablets already. So I'm tolerant already to the medication. Patients who are take one product and then come back and say that doesn't work, give me something else, and so you add on products, and so you end up with what I call the insomnia megascript. So patients who have 5 different products for insomnia that they're taking every night. Or you have patients who try one product for this month and then come back, that doesn't work, let's try another product, and then try another product, and then try another product, and none of them seem to work. Now, these patients are not addicted, they're not tolerant, there's no actual problem with the medication. There's a problem with the diagnosis, and the diagnosis is wrong. And part of the reason why this happens to us quite regularly is patients come in, and when they ask about insomnia and they ask for help, they will say to us, please give me something to help me sleep. So it's very clear that what they want is a product. They want a medication to help them sleep. What they should be asking is, please could we look into why I can't sleep? Please could we look into the mechanisms? Please could we assess this? But that's generally not what they ask, but that's what we need to do. So this group of patients are the group of patients that we need to look at very carefully as to those secondary causes, the restless legs, the sleep apnea, the delayed sleep phase, the naturally short sleeper, those patients on medications that might be interfering with sleep. Because if they do have these biological disorders, then the medications are really not likely to work at all. The hypnotics, no matter what hypnotics they are, they're really not likely to work. So we have to look at the diagnosis. You also have to look at when they're taking the medication. So often patients will go, so I'm taking my medication at 7 at night so that I fall asleep at 9. Well, I mean, that's crazy. That's not going to work. They need to move their bedtime later. And often if you just move bedtime later to 11 o'clock, for example, and they take the medication half an hour before that at 10:30, the medications work much better. So important to look at the timing, important to look at how long they're actually spending in bed, what they're trying to create. In the elderly patient, we need to be particularly careful of advanced sleep phase syndrome. So often in retirement homes, the elderly patients will have dinner at 5 or 5:30 in the afternoon, go back to their own rooms at 7:30. They're now bored because there's nothing to do, and they'll go to sleep at 7:30. And they'll wake up at 2 o'clock in the morning, come to us and ask us for something to help them sleep through the night. You have to make sure you get the history, because if they're sleeping from 7:30 until 2 in the morning, they're getting nearly 7 hours of sleep, which would be normal for them. trying to then sleep from 7:30 at night until 6 in the morning is inappropriate for that age group. And the last time they slept that long was when they were 3 years old. So it's completely inappropriate to give them medication. And if you don't get the history right, you're going to miss that. So really important to get a history, even if they just ask for a tablet, right? I need to ask you some things about your sleep. So ask them what time they're going to bed, what time they're waking up. Do they have restless legs? Do they have sleep apnea? Are they sleepy at night? Part of the reasons why sleeping tablets doesn't work is because they take them, for example, at 10 o'clock. And if you ask them, are you sleepy at 10 o'clock? They go, no, I'm not sleepy at all. So they're using the medication to create all of the sleepiness. There's no biological sleepiness at all. And that's guaranteed to create a problem with medication. The evidence that we have is there's no benefit and there's actually no evidence to combine medications for sleep. So there's only one study that's combined a sleep hypnotic with melatonin, and what they showed is that actually you increase the side effects of both of them. And part of the reason is because most of these products use the same enzyme system in the liver, and so if you block that enzyme system, the side effects for the medications increase significantly. So importantly, if you're giving a medication for sleep and it doesn't work, take that medication away, reassess, make sure that you have the diagnosis correct, do some CBTI, which we're going to talk about briefly in a moment, do some CBTI and see if you can get the medications to work. So 3 different groups of patients: patients who are clear addicts, who are using sleeping tablets as part of their medication profile, people who are on a very stable dose, sleeping well, very functional during the day, and then people in which the medications appear not to work, no matter what you try to do. So if we don't use benzodiazepines, what are our options as medical professionals, as scripted medication? What are our options? So a lot of doctors will use antidepressants and will use antipsychotics. And in fact, the Insomnia megascript often looks like they're on a benzodiazepine, they're taking melatonin, they're often taking an antihistamine, an antidepressant, and an antipsychotic. So those are the 5 medications that are put together to see if that cocktail will help assist in sleep. Now, there's no question that those medications work for sleep, that they do help patients sleep. But the evidence, and we are expected to practice evidence-based medicine, the evidence for that is just not available. So, for example, for the antidepressants, the evidence is not there that they universally improve sleep in all patients. The evidence is there that there are a lot of side effects that occur with the antidepressants. So dry mouth, weight gain, problems with eyesight, for example, and sedation into the morning so that patients wake up sedated. If we look at the antidepressants, and we look at the international guidelines, which come from the American Academy for Sleep Medicine and the European Sleep Research Society guidelines for the treatment of insomnia, the European guidelines recommend the use of these products, but only for 3 weeks as a short-term solution, and the American Academy does not recommend them at all for managing insomnia. The other group, the antipsychotics, also producing huge amounts of sedation, but also have similar side effects because the sedation that is provided by both the antidepressants and the antipsychotics is an antihistamine effect. So the antipsychotics are also likely to cause weight gain, sedation into the day, and other side effects. But there are patients who sleep extremely well on these products. I'm just going to say this again. I'm just saying the evidence just isn't there. There is no good research evidence to show that they work well in patients who have insomnia. More significantly about the antipsychotics and the antidepressants is that the sleep effect that we're using them for is a side effect of the medication, and these medications have actual effects. So the antidepressants, effects on serotonin in the brain, the antipsychotics, effects on dropping dopamine in the brain. And those may have significant effects in the long term in normal people. So we are using antipsychotics in patients who are not psychotic, and there may be consequences to that. There certainly are consequences in patients who have restless leg syndrome, which is driven by dopamine, with a drop in dopamine in the evening. And if you then drop the dopamine further with an antipsychotic, you may increase the restless legs. If patients aren't clear that the restless legs are causing the insomnia may in fact get worse on an antipsychotic. So a good reason, you need to check for restless legs before you use those medications. What is important about these particular medications, the antidepressants and the antipsychotics, is that often doctors will use them because they are afraid of the addiction dependency potential of the benzodiazepines. It's really important to understand there is no evidence for either antidepressants or antipsychotics that they do not cause dependency or addiction in the long term. There is no evidence that they don't do that. So we're using products which we have no evidence for the problem that we're trying to avoid in the first place. So it's really important to understand that. So benzodiazepines work extremely well for sleep. We know that. There's really good evidence that they work well. What we tend to do is be afraid of them because we don't understand the addiction dependency kind of story that goes behind that. So let's look at what that evidence is. So let's first look at addiction. So patients come to see me and they say, I'm really worried that I'm addicted to sleeping tablets. And I say, what do you understand by the word addiction? And they go, well, I can't sleep without the tablet. And I go, that's not addiction. Addiction has a very specific definition. And before we shame our patients into calling them addicts, we need to understand that definition. So addiction, the definition of addiction is a chronic pattern of compulsive drug seeking associated with a loss of control, preoccupation and anticipation, and continued use despite psychosocial dysfunction and distress. Now that's an addiction, and you can understand, everybody understands how that happens with heroin, right? Heroin users are addicted to it. They will use heroin, they will get money and use it for heroin even if they need to feed their kids, even if they need to pay for their bond. That's what an addiction is. And we need to be honest, like most of our patients who take sleeping tablets do not behave like this at all. They are well functioning, they are sleeping well, they do not have compulsive drug seeking. No one goes to rob a bank to go and buy sleeping tablets. There's not a loss of control. They often feel there's a loss of control because they're not in control of their sleep, but that is not what this definition applies to. There is not psychosocial dysfunction and distress. There's actually psychosocial function and non-distress because they're actually sleeping well at night. The data just isn't there that shows that patients who start a sleeping tablet are likely to get addicted. Are they likely to use sleeping tablets long-term? Very different to addiction. Are they likely to use it long-term? Yes, they are. Very few studies that take 100 patients that you start on a sleeping tablet and how many of them are still on the sleeping tablet a year later. One study done in the VA system in the US showed that only 20% of patients who were started on a sleeping tablet used it long term. Why would they use it long term? Because they're not offered any other treatment for the insomnia. So we need to look at insomnia if we believe, as people who do sleep medicine believe, that insomnia disorder is a disorder and it's a self-sustaining disorder, that if you don't treat the underlying problem, you are managing the disorder. And so just as you manage hypertension, if it's essential and you don't know what the underlying mechanism is, and you give antihypertensives to that, you are managing the disorder. Now, just as for antihypertensives, if you take away the medication, the hypertension comes back. Same thing with insomnia. If you take away the medication, the insomnia comes back. That is then wrapped up in a whole thing of addiction and dependency kind of shaming. But it's not. I mean, nobody should be surprised that if you don't offer any other treatment for the insomnia, but you're managing it with a benzo, and you take away that benzo, that the insomnia comes back, that should not be surprising at all. Because that is just recurrence. So that is recurrence of the disorder that comes back if you take away the medication. And so that is the reason why patients stay on it long term, is because if they come off it, the insomnia comes back because they're not offered other treatment. Recurrence is different to rebound. So what you get with rebound is when you take away the medication, you get an increased effect, which is due to the loss of medication. So the easiest one to talk about here is alcohol. If you drink too much alcohol, yes, you will fall asleep, but you will wake up in the middle of the night feeling very alert. So there's a rebound. There's an increased effect of that alertness that's happening because the medication, i.e. alcohol, has been resolved or metabolized, and now the increases come back. So certainly you can get a rebound effect. What you tend to get in patients with insomnia is a rebound in the anxiety. So patients who've been taking medication, you take it every night and you're absolutely stable on that and you're fine, and then you go, I think I need to come off this medication. So you take away the medication. Usually what patients do is they just stop it because they've run out. They just stop the medication. Let me see if I can sleep. But from the minute they think about sleep, they're getting incredibly anxious about the fact that they have no medication, and are they actually going to sleep? Their anxiety is now much higher, so there's a rebound in the anxiety that they have about their sleep, and then they're even less likely to fall asleep at night. So that is often the rebound effect. And that's also couched, and you see you're dependent on the medication. Well, every patient who takes antihypertensives is dependent on that medication to keep their blood pressure low. They're dependent as well. So insomniacs are dependent on their medication. Is there an added psychological dependency with insomnia? Yeah, there is. But is that about a bad dependency that we need to take them to a rehab center or something? No, it's not. It is the psychological dependency that if I have my tablet to sleep, I don't have to worry, i.e. get anxious about my sleep. And if I don't get anxious about my sleep, I'm more likely to sleep. So the psychological dependency is driven by the anxiety, and because insomnia is a disorder, unlike antihypertensives, you take them away, you may not notice any effects at all. Insomnia, if you take one tablet away, you're going to notice the effect immediately. So that kind of drives the dependency. The last component of this, so if you take medication away, you're going to get recurrence, you might get rebound, or you might get withdrawal symptoms. Withdrawal symptoms are new symptoms that are not related to the original disorder, but are related to the medication. So this might be, for example, and it occurs in some of the benzodiazepines, that if you take them away, you can feel nauseous, you can feel very fatigued, you can get headaches. Now, these are not things that are either related to the insomnia, but they're new things that are related to the product itself. And the data would say that only 1/3 of patients who are coming off benzodiazepines are going to get withdrawal symptoms, and those can be managed. They can be managed by slowing down the rate of withdrawal, for example. So if you're tapering medication, reducing the medication gradually over time, you slow that whole process down, and then the withdrawal tends to go away. So withdrawal symptoms may be there, but they're certainly not a reason to shame patients. They're certainly not a reason why patients shouldn't be able to get off medication. Let's look at how should we manage these patients. If patients want medication, how should we manage them? If patients have acute insomnia, an acute life stress event, and they're just not coping, please give them a benzodiazepine. Don't give them 30 days. Give them 7 days. Ask to see them after 7 days to see how they're doing, because you may be able to just stop the medication at that point. But if we're looking at patients who have an insomnia disorder, it's been going on for a long time, particularly if they want to come off the medication, what we need, the only real treatment for insomnia is cognitive behavioral treatment for insomnia. It's not the same as cognitive behavioral therapy. Generally, it's a very specific program. What's really interesting is that the behavioral component of that is really easy to do, and every doctor should be doing it in patients with insomnia. And it comprises 3 main things. The first thing is sleep restriction. So remember, I mentioned that insomnia patients are likely to go to bed earlier and wake up later and extend the time that they need to be in bed. A simple question of how much sleep do you think you need as a minimum? Patients may say 6 hours, and then to find the 6 hours that they spend in bed. Patients will be horrified that you are restricting their time to 6 hours. But if you explain to them that what the brain does if you restrict the time in bed, is that the sleep consolidates and then becomes much better and deeper, and it's the recognized process for treating insomnia, patients usually are prepared to try it. So it's about going to bed at 12 and getting up at 6, for example, or going to bed at 11 and getting up at 5. So that's the first component, sleep restriction. What sleep restriction does is biologically increase the sleepiness that patients have and make it more likely that they will fall asleep. The second component is called stimulus control, and the stimulus we're trying to control is the head running and being very active when they're lying in bed awake. So combined with sleep restriction, the stimulus control says that you go to bed, try to fall asleep. If you're not asleep in 15 minutes, you get up out of bed and do something that is likely to make you sleepy. Because after 15 minutes, you're not sleepy, you're wide awake, and now there's no point in lying in bed. So get up and read a book, for example, listen to a podcast, do something that will just distract your head a little bit, entertain you a little bit, and allow the sleepiness to come back. Once the sleepiness is back, you go back to bed again, and there's a better chance of you falling asleep if you're sleepy. But you may need to do that a couple of times before you actually fall asleep. So that is something that we add to the sleep restriction. And then finally, the third component is to keep a sleep diary. There are multiple ways of keeping the diary. I like giving them a page with 7 days on that so we can see the trend as what's improving over a period of time. That is the treatment for chronic insomnia. Now, you can apply that process to patients who are not responding to medication, because often if you do that at the same time, they do respond to medication better and they sleep better. You can also, using that process, applying the CBTI to patients who want to come off medication is very useful, because the data would say that you can taper medication and just gradually decreasing the medication over time. And if you do that, about 30% of patients can come off medication. But if you add the CBTI to that process, 3/4 of patients can come off medication and stay off medication for a year. So it's a really good program. And the difference is because you're actually treating the insomnia underlying it. So remember I said that if you take away the medication, you get recurrence of the symptoms. If you do CBTI at the same time, you're actually treating the insomnia, the underlying insomnia, and it's less likely to recur. So treatment for chronic insomnia disorder may include hypnotics, but it should always include CBTI as well. And combining those two, we can get a better treatment process for the patient. So in summary, please assess patients properly for insomnia. We need to know that if we're using medication, whatever medication we're using, that we're using it for the right disorder, i.e. insomnia disorder, which by definition is not caused by anything else. So let's exclude all those patients who have clear causes for the insomnia. When we use hypnotics, let's use the lowest dose that we can. So not all patients need to start on a full tablet of anything. They can always start on a quarter. They can start on a half a tablet. You can always use intermittent dosing. So the intermittent dosing is when you would not give them a tablet every night, but give them a tablet every third night. I think too quickly we kind of go, here's 30 tablets, take one every night. Instead of maybe we should start, and the evidence would say it's as effective as every night, less likely to have rebound, less likely to become dependent on them, and works really well. So maybe we should, every patient who starts on hypnotics, we should say, I'm giving you 3 a week. Pick the nights that you want to take them, but you're going to take 3 a week, and that's all you're going to take. And I'll see you in a month's time, and let's see how you're doing. That would be a more useful way to target the use of benzos, hypnotics, or any drugs. So the lowest dose possible, the lowest number per month possible, and that is the way that we should start. Patients who are currently on benzos, if they're very stable and they're sleeping well, then there's no reason not to continue that, because you are treating the disorder properly. Always have a conversation with the patient. Say, do you want to get off? Do you want the insomnia treated? Do you want to go for CBTI? Explain to them what that is and give them the options for doing that. If there are patients who are problematic, who are taking high doses, who are taking multiple medications, then if you don't feel comfortable managing that process, please refer them to somebody who will be able to do a good assessment for the sleep. If you're concerned about sleep apnea, send them for a home study for sleep apnea so that you can see that that's there or not. And just really do a proper assessment for the insomnia, because you may be trying to treat the wrong thing, and that is why the medication isn't working. So I hope that was all helpful, and I hope that you will feel better equipped to manage patients who are on sleeping medications, and better equipped to explain these complicated processes of addiction, withdrawal, and dependency to them, so that they don't feel so worried, to be able to manage their insomnia correctly.
You've been listening to another production